Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research. And we're here to explore a wide range of topics with you through interviews with content experts.
Hello, AAOMPT listeners. Antigone Vesci here, and I am excited to share the next and last interview from the AAOMPT 2021 Hybrid Conference. Today we have Dr. Kimberly Durant and Dr. Meghan Musick, whose presentation was titled The Fourth Trimester and Beyond. Before we begin, let me tell you a little about them. Dr. Durant has been treating as a physical therapist for the past 11 years. After receiving her degree from Gannon University, she attained her orthopedic specialist certification from the APTA in 2016. Her commitment to learning led her to complete a fellowship in orthopedic manual therapy at Regis University in Denver, Colorado in 2018. Dr. Durant has been teaching orthopedics to physical therapist assistants for the past 5 years for 2 separate PTA programs in Maryland. Over the past 3 years, Dr. Durant has taken further education to treat pelvic floor dysfunctions. Dr. Musick earned her doctorate of physical therapy from the University of Maryland in 2010. In 2014, she completed the Orthopedic Manual Therapy Residency Program through EIM, Evidence in Motion, and then attained her Orthopedic Clinical Specialist certification from the APTA in 2016. In 2018, she completed the Pelvic Health Residency Program through EIM and has since been on a mission to assist in educating fellow orthopedic therapists on the importance of routine pelvic floor screening. Most recently, Dr. Musick has started a pelvic health program at her local hospital and has developed a continuing education course for in-house staff. Kim initially interviewed with us after last year's AAOMPT Conference, episode 63, with the focus of bridging the gap between pelvic health and orthopedic physical therapy. There will be a similar theme to this conversation. I thoroughly enjoyed this presentation, not only as a clinician, but also as a new mother. My daughter, Melly, attended her first AAOMPT conference this year as a 5-month-old. Dr. Musick, welcome to the podcast, and Dr. Durant, welcome back.
Thank you for having us.
Yes, thank you.
I'm so excited to dive into this conversation. This is a growing area in our profession, so my first question for you both is, what inspired each of you to join this movement?
Yes, that's a good question. So I got to be honest, I had no interest in pelvic health whatsoever when I came out of PT school. And I remember my first job out of school, they actually tried to get me to go down the path of pelvic health. And I was very adamant against it. I wanted no part of it. So it wasn't until about, I guess, 5 or 6 years into my career, I was reading a case study on a female runner who was diagnosed with a proximal hamstring injury. And it turned out that there was some pelvic floor muscle involvement. Around that time, I had also been listening to a couple different podcasts, and they had a guest on there that was a pelvic floor PT who was also very orthopedic minded. So those were just kind of light bulbs going off when I read the study, heard the podcast, and I realized that if I really wanted to treat the whole person and be effective in my treatments, I had to stop ignoring this entire section of the body.
My journey was pretty similar, other than the person that did that for me was Meghan, and that she kept showing me different articles and showing me that we were missing a big part of the puzzle, especially with our low back pain patients. And I blew her off for a little bit. I didn't want to believe her. And then she showed me the case report from the 2013 for the proximal hamstring tear. And that case report is a really nice example of tying orthopedics with pelvic floor in a way that they knew when to refer out. And then also they still used a lot of orthopedics. So once I read that and realized the huge connection, it just kind of became a new passion to bridge these two worlds together.
I think that's great. And I hope this conversation inspires that for many clinicians, because I think that's a very consistent experience. I think we are a little shy about the pelvic floor, and the more we learn about it and the more we realize how important it is in treating the whole person, more of us will jump on that train. So great for you both to be early adapters and hopefully springboard this message. I know many like myself that attended your presentation became inspired, or hopefully at least a little more aware of the importance of us as a profession to be assessing, integrating, and respecting the role of the pelvic floor in our treatment, especially those with lower back pain, which was something that makes sense to me, but was really brought out in your presentation. Kim, you started off with some pretty scary statistics on the prevalence of pelvic floor dysfunction on low back pain. Can you detail some of those for our audience?
Yes, so there is a lot of nice research tying the incidence of pelvic floor and low back pain and hip pain. Our course focused more on the postpartum population, but still there's a nice correlation there as well. 37% of people are still experiencing low back pain into 18 months postpartum. So it's something to not be ignored, even if the person is further out in postpartum world, that it's obviously still could possibly be an issue. And there's a huge study done by MacArthur that followed 3,700 women over 12 years. And what they found that, unfortunately, with urinary incontinence, if it was present at 3 months postpartum, it was more than likely present at 12 years, that 77% of the women still had it at 12 years. So urinary incontinence is something that does not go away and something that we should be screening for.
I think that's an important point because oftentimes we hear, and I heard it too, just having my baby, that, oh, this will get better with time. You're still healing. Just give it time. That was such a profound study to show, no, it doesn't get better with time, and something we can definitely detail to our patients to encourage them to seek pelvic floor physical therapy.
Correct. Yeah, it doesn't get better with time. And so just having those conversations with the patient that you're already treating for low back pain or hip pain, you'll be amazed with how many will say yes when you start asking these questions.
Does any pelvic floor dysfunction get better with time?
I would argue that most of these diagnoses don't get better with time. That if anything, just like anything else in orthopedic world, usually you see a continuation of just things progressively getting worse.
Yes, just to piggyback off of that, we've had two great articles come out over the last year. One was in the British Journal of Sports Medicine, and the other one was in JOSPT. The one in JOSPT was a systematic review, and they found that pelvic floor symptoms adversely affected a woman's ability to exercise. So these symptoms are negatively impacting quality of life, and it's going to trickle down into other health conditions, heart disease. I mean, we know all the negative effects of not moving, not exercising. So it extends well beyond just the pelvic floor.
That's great. And so, what point should we be educating our patients, our friends, our families, et cetera, to maybe seek out physical therapy if they are reporting some of these symptoms postpartum?
Yeah, I would say when they go for their 6-week checkup postpartum, if they are still experiencing symptoms at that point, that's a great time to speak with their OB and request a referral of physical therapy. And there's definitely more things to look out for besides urinary symptoms. I think we're going to talk about this more as the podcast goes on, but there's certain symptoms associated with pelvic organ prolapse. And that's definitely something that can negatively impact someone's life and exercise participation.
I know that for myself, after I heard your talk and being a private practice owner, I added multiple items to our intake paperwork. I think the most impactful addition was a line of questioning regarding the number of pregnancies, births, mode of delivery, and just a place for patients to list any special circumstances like forceps use, tearing, long second stage of labor, because you pointed out that all of these things are highly correlated with pelvic floor dysfunction. Just by getting more information, it has made me so much more aware going into my evaluations because it wasn't something I was explicitly asking unless they really offered it into my subjective beyond bowel and bladder changes, which is the common thing we hear and say, but may not really be a strong invitation for someone to open up about their experience. Besides some questions like these, do you have any other screening tools or questions that a therapist could incorporate to better identify and serve these patients in their intake paperwork?
Yes, so there's 3 different screening tools that you can use, and these are all Googleable. There's the Cozine screening tool, which just asks a series of questions in regards to pelvic floor. Also looks at coccyx pain, just very generic questions. I think there's like 9. There's the AAOMPT screening tool that was just developed by Kelly Wilson and the rest of the special interest group this year. That's, I believe, is available on the AAOMPT website. And there's also a super generic 3 incontinence question tool that you can look up as well that pretty much just says if you've had any leakage in 3 months. From there, they ask you a little bit more specific, whether it's urge incontinence or stress incontinence. And the sensitivity of that screening tool, which is only 3 questions, is actually pretty high. So something that's really helpful to help screen to see whether these patients potentially are appropriate for some kind of pelvic floor intervention, not necessarily internal, but maybe just external.
I also just want to point out that No one's asking these questions. The OBs aren't asking, the primary care physicians aren't asking, they're not screening for pelvic floor dysfunction. They're not even screening for risk factors associated for levator ani tears, which are huge when it comes to pelvic organ prolapse. In one study, out of 1,500 women who saw their primary care physician within 12 months postpartum, only 25% of them were asked about urinary symptoms, and less than 20% were asked about fecal incontinence. So a lot of these women are getting missed, and they may be having back pain, hip pain, and that's how we can really make a big difference with these individuals.
That's such a great point and an astounding statistic. I think that we as physical therapists with direct access have such a strong role here to impact these patients, because we often might be seeing them for low back pain or something else pre or post delivery, and can put this on their radar that, hey, if you're experiencing this greater than 6 weeks postpartum, you really should come back and we can help address that, versus kind of being on the back end of it and either not asking the question at all and now it's progressed. The more that we can have this conversation, be comfortable having this conversation, it will only help to serve our profession and our patients. I really liked how you both made us ask and practice asking difficult questions within the session. Can you just provide an example for our listeners as to how you would ask pelvic floor and sexual health related questions, just so we can have an example of how it might sound?
You already mentioned moving beyond just the generic bowel and bladder question. And I'll admit, I did that for many years and, I never followed up on that. But yeah, it's so important to really be specific, because most times if you just ask, do you have any changes in bowel or bladder function? They're going to say no, even if they are experiencing urinary symptoms. So be more straightforward. Ask if they're having any leakage, even drops with laughing, coughing, sneezing, lifting, running, jumping. Also asking if they have a strong sense of urgency or any urinary leakage, if they have to rush to the bathroom. Touch on bowel symptoms if they have a history of constipation, because we know that that can definitely lead to some overactivity in the pelvic floor muscles, and that can be a contributor to some back symptoms. Sexual health related questions, I think this is probably the most challenging one, but usually I try to preface it with, there's a group of muscles that sit in your pelvis. They're called your pelvic floor. They actually can play a significant role when it comes to back and hip pain. So I'm going to ask you a couple questions that may be a little more personal. Do you have any discomfort or pain with gynecological exams, tampon insertion, or intercourse?
Just to piggyback off Meghan, I think the important thing with asking these further questions is making sure the patient feels comfortable and just maintaining eye contact the whole time. So if they're telling you things that you really don't know how to digest, just making sure that don't look away when they tell you something. I think that's so crucial. So just creating an environment where they feel comfortable enough to answer these questions and not immediately go to the denial of no, I'm fine. I think that's so important as well.
Totally. And you don't even have to ask these questions on the first day. If you want to develop a little bit of a rapport with the patient first and ask on the second visit or even the third visit, totally fine.
I think that's a great point. And often giving patients time and space to answer that, because a part of us secretly is hoping they'll just say no, we don't have to address it because we're uncomfortable. But they know that you are screening and they kind of want to move on, but giving them some time and space and eye contact and making it a brave space for them to share their experience.
And most of the time, it's a relief that a medical provider is asking them further questions about it. So they instantly get like, why are they asking me this? Can they actually help me with this? And there's almost like a level of excitement, like, hey, maybe this can get better. They just have managed it poorly for so long because they thought it was normal. So asking further questions sometimes can be met with enthusiasm, because just like I said, you could be one of the first medical providers to ask a follow-up question about it.
My hope is that this conversation inspires our listeners, like your presentation inspired me, to begin to incorporate the pelvic floor into their arsenal of treatment with patients. What are some simple but impactful things that you could perform or that we could perform in an objective exam to help evaluate the function of the pelvic floor for the physical therapist that may be not as familiar with it?
One simple way that you can start is just by evaluating a person's breath. We do have some good studies out there that have looked at the link between the diaphragm and the pelvic floor. One study in particular that comes to my mind right now is a study by Talaz. And they did a dynamic MRI and they found that as the diaphragm descended upon inspiration, so did the pelvic floor. The pelvic floor elongated and moved. And then during expiration, same thing. The pelvic floor moved up, diaphragm moved up. So just by impacting the breath and paying attention to what their breathing strategies are is a great way to impact the pelvic floor without having to do any kind of internal treatment.
We evaluate breath all the time, and I don't know that we always think about its connection to the pelvic floor. And seeing dysfunction here should maybe, from a clinical reasoning standpoint, trigger us to look deeper and evaluate that, especially in a patient that is flagged with some of those screening type questions. Are there any other objective exam tools that you use to evaluate the function of the pelvic floor beyond breath?
Yeah, so there's a couple other screening tools that you can use that are all external. So the active straight leg raise is a really good test where it's just as it sounds. So the patient is supine and you ask them to flex their hip up in the straight leg raise pattern. And what's really cool about that is you can see if they are using a strategy that maybe is not efficient. So sometimes people with pelvic floor involvement, they might breath hold whenever you ask them to lift their leg up, or they might rotate, or they might do something interesting. So it's just a simple, quick evaluation tool. And then also comparing it to the opposite side to see if there's a difference between left and right, like we do with any other special test. There's another test that you can use that's actually pretty valid for screening of pelvic floor. It's the external coccyx test. You can have the patient do it if you're not comfortable. Patient pretty much puts their middle finger right onto their anus, and so then their other fingers are pretty much right on pelvic floor. So you can do this in sitting or in side lying, and you cue them to just do what they think a pelvic floor contraction is, have them relax, and then bear down. So ideally, whenever they contract, they should feel muscles go away from their finger. Whenever they relax, they should obviously feel the muscles kind of recoil. And when they bear down, they should feel more pressure into their fingers. So it's a nice biofeedback that they can go through themselves to see if they have a good awareness of it. Because a lot of what we treat is just coordination of pelvic floor. And that usually there are some interesting compensation strategies that are used in order to do what people believe is a pelvic floor contraction.
I think that's an easy thing for us to incorporate externally. And you mentioned low back pain and its correlation to pelvic floor dysfunction. How would you utilize that technique when maybe cueing someone to perform a pillar or core stability exercise?
So going back to the breathing pattern, what Meghan talked about before, recognizing the relationship of the diaphragm and the pelvic floor, and also realizing that there's a relationship between transverse abdominis and the pelvic floor. So whenever we exhale, pelvic floor should lift and transverse abdominis should also contract. There should also be a nice relationship between those two as well. So if you're training to do any kind of core coordination, using the breath and using the exhale to try to get the transverse abdominis and the pelvic floor to come on together. That's how I use it with my patients with low back pain and hip pain that we're focusing on core coordination.
Yeah, I totally agree. I think getting away from teaching posterior pelvic tilt is huge when it comes to including the pelvic floor in your core coordination training. There's been some research out there looking at posture, and they've found that women who sat in more of a posterior pelvic tilt or stood in kind of a posterior pelvic tilt position and had reduced lumbar lordosis actually tended to have more pelvic floor dysfunctions. There was another study too looking at dorsiflexion angles, and they found that more dorsiflexion at the ankle was associated with more of an anteriorly rotated pelvis and greater pelvic floor muscle activation. So just getting someone off of their heels and trying to distribute their weight a little bit more evenly or even a little closer towards their forefeet can sometimes have a big impact for certain patients.
This was like an aha moment for me in your presentation because I feel like we often in the orthopedic realm are cueing patients to move their weight into their heels because we're trying to decrease stress on the knees and encourage glute activation. But from a pelvic floor standpoint, this may not be the best type of cue, or potentially with our patients with low back pain and pelvic floor dysfunction, maybe we should be encouraging more of a midfoot weight bearing and just be mindful of posturing here. So I thought this was super interesting. And then when you had asked us to blow up balloons and change our posture, I realized how ineffective I was at being able to blow up that balloon with my weight in my heels, which is exactly how I was standing postpartum and not something I noticed prior to having the baby. So I think because our belly grows, we kind of adapt that posterior weight shift to try to stay center. But once that's no longer there, correcting that is a really vital strategy for our patients.
Absolutely. Moving out of the post pelvic tilt, and that's a pretty common strategy because obviously the baby's growing, so you have to do something to adapt. So tucking the pelvis in and trying to protect the pelvis is a common pattern. So being able to move out of that is so key.
I think many clinicians shy away from treating this because they feel intimidated by internal treatment, or maybe they aren't interested in taking some advanced training. How much relief or success do you feel that you both get in patients externally? And at what point might you refer a patient for an internal exam?
I would say that probably a lot of the listeners have had a positive impact on the pelvic floor without even knowing it. They looked at vaginal squeeze pressure. So they looked at pelvic floor strength in a group of young women and a group of older women. And they basically just took the woman through a strengthening program for their glutes, hip abductors, and they did no training for the pelvic floor specifically at all, no internal interventions. And after 8 weeks of just working glutes and their hips, there was a significant increase in their pelvic floor muscle strength. So I think just incorporating a lot of those good glute exercises and, like we already discussed, the breathing, that's a huge piece, the posture, just finding ways that they can use their muscles more efficiently and just optimize the function of all these muscles working together is really impactful.
The two kind of diagnoses that I feel as though should benefit from an internal assessment would be patients that are complaining of prolapse symptoms. So feeling like the organs are falling out or kind of feel like something's not right. And then any complaint with painful sex, because that usually indicates there's some tension in pelvic floor that might benefit from internal work. Could also be a case where they managed with an orthopedic PT and then also an internal PT, similar to that case study they mentioned in the very beginning, that it could be an opportunity to have like a tag team therapy. But those are the two things that would be more than likely beneficial to have an internal assessment for.
Yes, also just knowing the obstetric risk factors and what to ask for and look out for that puts someone at risk for a levator ani avulsion tear. So as you already mentioned that you're including in your paperwork, asking about forceps use during delivery, long second stage of labor, age of mother when she gave birth to her baby, and perineal tears. Those are huge. If they had those, then their risk for levator ani avulsion tears is much higher, and that sets them up for pelvic organ prolapse. So being aware of that and getting them to a pelvic floor PT sooner than later so that they could do an internal assessment of those muscles is very important.
Yeah, I'm sure many of those are missed just because we're not asking the right questions or having someone take a look at that. I know for myself with pregnancy, there was surprisingly very little consensus on how long to exercise, how intense to exercise. What do you guide your patients on? How do you tell them when it's safe to return? And how do you set parameters for your patients?
So the parameters that are on the AGOG website are very generic. So they recommend 150 minutes of moderate intensity aerobic activity and postpartum, which could be interpreted multiple ways. And I get it. They have to make their guidelines very generic because, they can't obviously individualize them to every patient that is postpartum. So that being said, it's very, just like everything else in physical therapy world, it's very individually driven, given where the patient was prior to pregnancy, given what activity they were during pregnancy, what kind of labor and delivery did they have, any trauma there. All that kind of plays into recommendations and to return to activity. I will say there was wonderful guidelines that came out in the last couple of years. Meghan will know the author's names. Return to run parameters. And it's a free document that goes through multiple different functional testing to see whether a patient is ready to return to run specifically for postpartum. It's a great resource, especially if you have patients that are really dying to get back to running. And then even I will use it for my patients that aren't necessarily postpartum, but just are trying to get back to running. Just very general guidelines on how to test and see if they are ready to go back.
Yeah, those are great guidelines. It's called Return to Running Guidelines. You can just Google it and it'll pop up, but it's by Granier Donnelly, Emma Brockwell, and Tom Goom. And it was put out in 2019. Excellent, because until this, there was really no clear guidelines on returning to sport or running after having a baby. But I would say a good general rule of thumb is to stick with low impact activities for the first 3 months. You really want the body to have time to heal. Obviously, things are going to influence the speed of progressions if they're still breastfeeding. if there's obesity, if they had any complications with the birth, they had any underlying medical conditions, and even if they just have negative thoughts or fears or pre-existing pelvic floor issues.
That's a great point. There's the physical readiness from a healing standpoint, but there's also the mental readiness from that hormonal change and the life change of having a new baby and lack of sleep and all the other factors that are influencing mental and physical health at that time. We often think about strengthening the pelvic floor, but you both had a great chunk of your presentation talking about down training and how this can often be the issue and be underlooked. Can you just summarize what down training is and how we might potentially identify a down training versus strength issue in the pelvic floor?
Yes, down training is very important. Down training is, in essence, just relaxing the pelvic floor before we can strengthen the pelvic floor. So a lot of times people have an overactivity of their pelvic floor, which gives this false illusion that they really have strength, but in essence, it's just the tissues are overactive and tense. So what's really important is that we spend some time down training, meaning relaxing or lengthening those tissues rather than immediately trying to strengthen them. There is a great example that is used a lot in pelvic floor world of trying to do a bicep curl with just the elbow flexed at 90 degrees. Obviously, if you try to strengthen the bicep just with the elbow flexed at 90 degrees, moving from 90 degrees to 120 degrees, clearly the bicep is not going to truly get strong or be efficient. So same thing with pelvic floor. If we try to strengthen the pelvic floor without it actually going through the whole length and tension of the muscle, then it truly cannot really respond to strengthening. So spending some time just going over down training positions with patients that have this over recruitment is so valuable. And we mentioned in our presentation how it's not one size fits all. There's a multiple different positions that people can kind of tap into to see if they can feel that lengthening of the pelvic floor. And some of the common ones that I prescribe is happy baby. But happy baby, you need pretty good flexibility in your hips. So sometimes my older individuals can't get into that position. So a child's pose sometimes is more appropriate. Standing forward fold sometimes can be effective. And so these are all positions to see whether they can feel that nice lengthening of pelvic floor. So like I said, it's not one size fits all. Usually I spend some time just going through these different positions and seeing which one they like the most and which one do they feel like they can really feel that lengthening. And then adding in the breathing. Okay, can we talk about doing some nice inhales and exhale? Ideally on our inhale, we should feel that lengthening of pelvic floor. Can you feel it in this position versus other positions? That's something that's very valuable for people with an overactivity.
The big thing that we really wanted people to take away from that part of the presentation was to get away from Kegels. Stop telling people to do Kegels. Where in the body do we have people do 150 reps of one thing? We really want to, I guess, highlight the importance of moving through the whole range of the muscle, lengthening and contracting, not just contract, contract, contract.
And when you say feeling the lengthening, do you mean internally or do you mean with their hands as like a biofeedback?
No, see if they can actually tap into it. Some people can and some people can't. So if they really can't, then you can go back to, okay, can you kind of put your hand a little inside of your sit bones? Can you feel that those muscles kind of push into your fingers when you inhale? And sometimes that takes time for them to be able to feel it and to tap into it. So using biofeedback of themselves is helpful. And then sometimes just being patient. Some of the patients that have that overactivity, they can sometimes be anxious individuals, cueing them to be able to feel something. They might feel discouraged if they don't. So appreciating that it might take time for them to really feel this whole relationship and the whole lengthening of the pelvic floor.
And sometimes down training can really just be having a positive effect on the autonomic nervous system, trying to calm down that sympathetic system and get them to just kind of get in a more relaxed state, stimulate the vagus nerve, that kind of thing. So you can use mindfulness meditation, coordinate that with some of the stretches that Kim's already listed.
That's a great point and such a useful one to start to think through and incorporate as orthopedic manual physical therapists. We often associate the pelvic floor with females, and sometimes I would say wrongfully call it women's health, as there are some unique issues and challenges with pregnancy like we just mentioned. But as we all know, males too have a pelvic floor, and they often have dysfunction as well. Can you speak briefly on the issues that may be unique to men?
Yes, males have pelvic floors as well. We can't ignore the men. A large study that was performed in Canada in 2017 questioned both men and women. It was a Canadian consumer health survey. So the overall response rate with that was 78%. And what they found was that urinary incontinence was found to be strongly associated with the presence of back pain in both men and women. And actually, if you looked at the odds ratio, it was a little bit higher for men than women. Men are going to have similar issues as far as urinary side of things go, but when it comes to sexual function, the pelvic floor muscles play many important roles. Some symptoms that males may experience if these muscles aren't functioning optimally is difficulty achieving or maintaining an erection, premature ejaculation. They may have difficulty reaching climax, or they may have pain associated with climax. Pudendal nerve irritation is something that can happen to men that are cyclists or spend a lot of time on a motorcycle. So symptoms that they may feel would be like sitting on a golf ball or being stuck with a hot poker in their rectum. As far as the urination side of things go, they may experience some post-void dribbling, but all of those could be potential pelvic floor issues.
Would you assess and treat those similarly to what we just mentioned prior?
Yes, all the external interventions and assessments, I utilize those with both males and females.
Dr. Durant, Dr. Musick, thank you so much for your time today. This was a wonderful conversation and hopefully one that continues to drive this part of our practice forward. If any of our listeners wanted to seek any further education or mentorship or training in this area, do either of you have any resources or recommendations for where to start?
There's some great therapists out there that have external only courses. A famous one is Julie Wiebe. She has online learning and in-person learning, and it's all just external treatment. Another good one is Anthony Lowe. He's also known as the physio detective. I think Evidence in Motion has also recently started a pelvic floor ortho course that's all external.
Yeah, some other people to look up, the two fellows that are really strong in pelvic floor world is Kelly Wilson. Kelly Wilson is the president of the special interest group for AAOMPT for pelvic floor. She also has her own con ed company, and she's fantastic. She knows a lot. She's a great resource to look into. She does con eds. Susan Clinton also is a fellow and also is WCS as well. She has a podcast, Tough to Treat. She's a good one to follow as well. And then if you're interested in internal courses, Herman and Wallace, APTA, they both have internal courses. But like Meghan said, there's a few clinicians that just do external con eds, and Julie Wiebe is one of the biggest ones for that because she does a wonderful job mixing ortho with pelvic floor.
Thank you both so much for being on the podcast and for continuing your work in this area.
Thanks for having us. It was great.
Yes, thanks so much for having us.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aampt.org, which you can find in the show notes.